And on laryngoscopy, I found generalized inflammation involving the epiglottis, as well as the aryepiglottic folds, but no sign of any neoplastic lesion. Am I going too fast for you, Miss
It's
Hunt?
quite all right.
All right, continuing. Whatever the original etiology of this patient's chronic, non-specific laryngitis, I am sure it is being maintained by his heavy smoking, and I recommend cessation of this activity. He should rest his voice as much as possible and perhaps do inhalations with tincture benzoin co. A simple sedative cough linctus, such as paracodin, may also be of benefit. I will see him again in 4 weeks' time. Yours sincerely.
I've booked the appointment for him, Mr. Hilton.
Good, thank you, Miss Hull. And who is next?
Mrs. Fielder. Oh, here's her general practitioner's letter.
Thank you. She is 67, complaining of purulent otorrhea, increasing deafness, and latterly some attacks of vertigo, and a previous history of middle ear infection going back over 30 years, I see.
Come and sit down, Mrs. Fielder.
Well, Mrs. Fielder, so you have ear trouble?
Good morning, Doctor. No, I haven't been too well lately.
You've had an ear discharge, have you?
Pardon?
Ear.
Yes, it's in the right ear.
Now, let me have a look.
Round a bit. That's right.
Speculum, please. Thank you. Swab. And another. Oh, a lot of pus here. That's better. Take this down, Miss Hull, will you? Profuse malodorous discharge with large cholesteatoma protruding through a posterior perforation of the tympanic membrane. Swab, please. All right, sorry, my dear. There, that's done it. Send this swab to the lab, will you, Miss Hull?
Yes.
Now then, can you hear this?
Huh?
And on this side?
I can sort of feel it vibrating.
And which side can you hear it on now?
Oh, here, on the right.
All right, Miss Hull. Lateralization test to right. Rene negative on right. General conductive deafness on the right. All right, Mrs. Fielder, we'll give you some treatment here in outpatients to clear up the discharge.
Yes, yes.
But to make a good job of it, I think we ought to operate on that ear.
What? Pardon?
You ought to have an operation.
Oh, an operation.
Now, you go with the sister, and she will explain it to you.
Come along, then. This way, Mrs. Fielder.
Thank you, Dr. Hilton. Goodbye.
Bye-bye, goodbye.
Oh, look, sister, this is Mrs. Fielder.
Yes, I agree. Put her on the waiting list for modified mastoidectomy and tympanoplasty, will you, Miss Hull?
Yes, Mr. Hilton. I'll ask Sister to give her daily oral toilet here in OPD.
And I'll write to her GP later. Who is next?
A woman with vertigo. Hello, Mr. Hilton's clinic. Oh, Dr. Stevens would like a word with you, sir.
Oh, hello, Peter. Yes, the man with primary laryngeal carcinoma. What do you think? Yes, I hoped you'd give a good prognosis for him using radiotherapy. Good. Then we can review him together after 6 weeks cobalt treatment. Perhaps we can avoid laryngectomy. Thanks a lot. Goodbye. Now, the possible Meniere's disease. Have you got that letter from her GP?
Yes, I think I have. I'll just look it up.
So you'll be doing the next operation, Dr. Chester, all right? You know the patient, of course.
Yes, sir. A boy of 6 with chronically enlarged adenoids, cervical adenitis, and middle ear type conductive deafness due to chronic serous otitis media.
So you'll want to do a straightforward adenoidectomy and then a myringotomy to allow the middle ear effusion to drain, okay?
Yes, sir.
Oh, steady on. The anesthetic trolley is in the way. Just mind the oxygen tube. There we are.
Thank you, sir. Now, swab, please, sister. Adenoidal curette. Thank you. Forceps. Swab, please. Suction. Ligature, please. There.
Now, let me see. I'll adjust the fibre light. Oh, well done, Chester. Well, now the ear. We turn him on this side. That's it, sister. Thank you. And the operating microscope, please. Thank you, sister. Right, let's get it in focus. Here we are, Chester. That's 6 times enlargement. You can see bulging of the pars tensor of the tympanic membrane, but comparatively little injection.
Yes, indeed. My ringatome, please, sister. Thanks. Swab. And another.
Yes, and now a gauze wick soaked in adrenaline. Yes, now let me have a look. Oh, excellent, Chester, excellent. Another adrenaline wick, please, sister. Good, good. Over on his back again, that's right. Suction, please, sister. Laryngospasm. A little hemorrhage has oozed down and irritated the larynx.
Would it be all right to move him back to the ward?
Better keep him in the recovery room under observation for 10 minutes in case Stridor returns. What's the next case?
Mr. Vesey, for removal of multiple nasal polypi.
Oh, yes. He has suffered from perennial vasomotor rhinitis for years, and this is one of the sequelae of chronic congestion and infection. All right, sister, let's have him in.
The specialist in ear, nose and throat surgery is called an otorhinolaryngologist, but is usually called ENT surgeon for short. To examine the tympanic membrane, he uses an otoscope. Repeat, otoscope. This is also called oroscope. Discharge from the ear is called otorrhea. Repeat, otorrhea. Compare with rhinorrhea, discharge from the nose. Purulent otorrhea may be due to acute otitis media with rupture of the tympanic membrane. Repeat, otitis media, tympanic membrane. Otitis media may spread to infect the antrum. Repeat, antrum. Or reach the mastoid air cells. Chronic mastoid infection may require mastoidectomy. Sound is conducted from the tympanic membrane to the fenestra vestibuli. Repeat, fenestra vestibuli, by the ossicles. There are 3 ossicles, the malleus, the incus, and the stapes. Surgical removal of the stapes is called stapedectomy. Repeat, stapedectomy. This may form part of an operation for otosclerosis, to correct conductive deafness. Deafness may also be due to a disease of the membranous labyrinth, for instance, labyrinthitis. Repeat, labyrinth, labyrinthitis. Labyrinthitis can also cause giddiness and nausea, sometimes even vomiting. Labyrinthine giddiness is called vertigo. Repeat, vertigo. Sometimes vertigo. In Meniere's disease, the patient suffers from vertigo and deafness and tinnitus. Repeat, tinnitus. Deafness is investigated by audiometry or by use of a tuning fork. Inspection of the nose is called rhinoscopy. The septum and the inferior turbinal can be seen through the anterior nares. The middle and superior turbinals are best seen by posterior rhinoscopy using a mirror. The maxillary antrum drains into the nose through the ostium. Repeat, maxillary antrum, ostium. The frontal sinus and the sphenoidal and ethmoidal sinuses also drain into the nose. Repeat, frontal sinus, sphenoidal, ethmoidal. Inflammation of a sinus is called sinusitis. A trocar and cannula may be used to perform antral puncture. Repeat, trocar, cannula, antral puncture. Chronic congestion of the nasal mucosa is usually due to perennial vasomotor rhinitis. Repeat, perennial vasomotor rhinitis. Obstruction of the nasal passages can cause loss of sense of smell or anosmia. Repeat, anosmia. Obstruction of the nasal airways may also be due to enlargement of the adenoids. Repeat, adenoids. The lymphoid tissue situated in the nasopharynx. Repeat, nasopharynx. Enlarged adenoids may cause deafness by obstructing the eustachian tube, also called the pharyngotympanic tube. Repeat, eustachian, pharyngotympanic. The throat is called the pharynx. The adjective is pharyngeal. Repeat, pharynx, pharyngeal. The voice box, or larynx, occupies the lowest part of the pharynx. The larynx contains the thyroid cartilage, the cricoid cartilage, and the arytenoid cartilages. Repeat, thyroid, cricoid, arytenoid. The epiglottis lies between the larynx and the base of the tongue. Inflammation of the larynx is called laryngitis. Laryngitis may cause hoarseness or even complete loss of voice, aphonia. Aphonia and hoarseness may also be caused by intrinsic carcinoma of the larynx involving the aryepiglottic folds. Extrinsic carcinoma of the larynx, originating in the piriform fossa or in the subepiglottic region, repeat, piriform fossa, subepiglottic, may cause dysphagia as a presenting symptom rather than hoarseness. The unproductive cough, often found in diseases of the larynx, will derive symptomatic benefit from the administration of Decodit.